You can introduce yourself and get started.
Great. Thank you. Well, good afternoon, everyone. Thanks for being here today. My name is Claudia Guglielmo. I am a director for health promotions at the American Lung Association in New York. I'm a certified asthma educator and have been one for about 15 years, I guess now, approaching my 15-year mark, I guess. And I'm here today to talk to you about Project Breathe New York and how we use quality improvement to drive our work and improve outcomes for children with asthma in New York State. I think that you will perceive my enthusiasm for our asthma work. I like to tell people I live in asthma utopia. So I hope that I can encourage you to join us on this asthma utopic trip. Let me see, is it going to advance the slides? It does. All right. So Project Breathe New York is a joint initiative of the New York State Department of Health's Asthma Control Program and the American Lung Association. And the project aims to expand the delivery of quality, guidelines-based asthma care across health systems in New York. Not only are we so fortunate to have this amazing partnership with the Department of Health in New York State, we have a team of esteemed faculty advisors, which you can see here on the screen, who help guide our work with their expertise in both clinical and quality improvement initiatives. Project Breathe New York provides a comprehensive framework to enable health systems and community-based partners to collaboratively improve health outcomes and quality of life for children with asthma and their families, and reduce avoidable asthma-related hospitalizations and ED visits. Project Breathe New York integrates evidence-based asthma care coordinated across settings to improve quality of life and health outcomes for children with asthma and their families. It provides a framework for hospital, inpatient, ED, and primary care settings to adopt best practice strategies and tools for training providers and patients, driving quality improvement, building clinical community linkages, and addressing health equity and social determinants of health. So how did all of this great work get started? And I have to admit that we are coalition workers, so we steal shamelessly, share seamlessly. So I'm the first one to admit when I steal some ideas. And I kind of love this graphic because as we were moving our coalition work to a more quality improvement slant, we saw this reaction like, great idea. We have way too much to do. And you know what? We know everything about quality improvement and our hospitals got something in place. But fortunately for us and my colleagues, I should say, a local hospital reached out and said, we know there's more we can do to keep our asthma frequent flyers from regularly coming back to the hospital. The rest, as they say, was history. We know this approach works based on piloting this approach at several local hospitals on Long Island in New York. Beginning in 2012 and based on our past QI work with the New York State Asthma Control Program, we developed an approach which we then called Breathe, a little different than Project Breathe New York, which had an acronym of bringing resources for effective asthma treatment through health education. I'm sorry, there's a little lag of the slides. So looking at the results of one of those projects back in the early days, you can see that we realized a 50% reduction in children who had more than one admission in the year before the index or the Breathe visit. When we looked at our data, we had about 775 patients enroll in Project Breathe. When we started to clean our data, we excluded children with significant complex medical problems, severe chronic lung disease, RAD, and then using the health system's EMR, we identify asthma-related hospitalizations occurring 1 year before and 1 year after the index visit or the Breathe intervention. Many of the children had only the index visit, so no hospitalizations for asthma in the year before. I should preface this by saying this was never meant to be done as a controlled, randomized control trial, right? This was really purely QI, and we needed to figure out a way to see what our impact, how much impact we had made. So only 34 of the 470 who were readmitted for asthma in the year post their breathe intervention, 98 of those 568 children had multiple admissions in the 1 year prior to enrollment, and they had 61 post breathe intervention. This population we felt represented children whose asthma is more difficult to control. And so we thought they were a good indicator of some sort of outcome impact that we had. So we had 122 hospitalizations for those 98 kids 1 year prior to Project Breathe, and 61 post Breathe intervention index visit, which was about a 50% reduction. Not only did the early Breathe projects realize a reduction in hospitalizations for children with asthma, but we also saw some other really kind of cool impacts throughout health systems. One was some of the participating hospitals used the Project Breathe framework to achieve magnet designation. Breathe served as a model project for JCAHO accreditation. Not something we set out to do, but when they were observing the pediatric units, they were very impressed with the work that was going on. Our Breathe project also was used to develop a residence team-based learning program using the asthma guidelines. Breathe allowed for enhanced nursing education, including many nurses who were part of our original projects achieving asthma educator certification. One other impact that we found, and we still find kind of amazing in this world of healthcare cost escalating, was some of the hospitals who were engaged in Breathe recognized the impact of the project and were willing to provide a salary line for a dedicated nurse who is a certified asthma educator to coordinate those Breathe implementations. And lastly, we realized that this project and its bidirectional communication really improved communication with outpatient providers for follow-up. So we brought together all the research and experience we have, and Project Breathe New York was born. The development of Project Breathe New York is built on nearly 2 decades of national and state asthma quality improvement initiatives and evidence-based interventions. For over a decade, with support from the CDC's National Asthma Control Program, the New York State Department of Health has led annual statewide asthma quality improvement collaboratives to engage over 100 health system project teams in improving the delivery of guideline concordant asthma care in the highest asthma burden areas of New York. This work helped to form the development of a pilot initiative that I mentioned before, with the acronym Bringing Resources for Effective Asthma Treatment Through Health Education. It was implemented by 2 New York State regional asthma contractors with the American Lung Association, the Asthma Coalition of Long Island, and the Asthma Coalition of Queens, which I started back in 2012. The Breathe pilot worked to integrate asthma self-management education and the Community Guide's 2008 findings for strong evidence for home-based, multi-trigger, multi-component environmental interventions for children with asthma by linking health systems to home-based asthma service delivery partners. Nationally, improving the quality of asthma care and related health outcomes are prioritized by the CDC's 618 initiative, launched in 2015, which targets 6 common and most costly health conditions, including asthma. 618 was developed with the goal of partnering with healthcare purchasers, payers, and providers to improve health and control healthcare costs based on rigorous evidence, identifies proven interventions, and aligns evidence-based preventive practices with value-based payment and delivery models. For asthma, the 4 interventions included following the NAEPP guidelines for medical management to reduce asthma symptoms and healthcare use, including ED visits and hospitalizations. promoting access and adherence to asthma medications and devices, increasing patient opportunity for self-management education, and lastly, targeting home-based asthma services to individuals whose asthma is still not well controlled through proper medical management and asthma self-management education. In response to the 618 initiative, the CDC National Asthma Control Program launched the C-CARE initiative, Controlling Childhood Asthma Reducing Emergencies, with an accompanying technical package, which many of you probably have heard of, Exhale, which aims to prevent 500,000 emergency department urgent care visits and hospitalizations due to asthma by August 31st, 2024. Exhale strategies include E, education on asthma self-management, X, extinguishing smoking and secondhand smoke, home visits, achievement of guidelines-based care, L for linkages and coordination of care, and E for environmental policy. This foundation formed the basis of our current work and resulted in the adoption of this model for improvement, which forms the foundation for Project Breathe New York work. We use the model for health for improvement, which asks, what are we trying to accomplish? Our aim. How will we know that a change is an improvement? We collect data and do monthly data checks. And lastly, what changes can we make that will result in an improvement? What are ideas, hunches, and about how to move the needle on our asthma care to get outcomes? I wanted to provide you with a little background on where the work gets done in New York State. Currently, the American Lung Association receives funding for 4 regional asthma coalitions implementing the Breathe work throughout New York State. You can see where these coalitions are located by the colors on the map. In Western New York, we have the counties of Erie, Monroe, and Niagara. In the Hudson Valley, we have the counties of Dutchess, Orange, Sullivan, Ulster, and Westchester. We work in 4 boroughs of New York City, Kings, Queens, Richmond, and New York. And we work on Long Island in the 2 counties of Nassau and Suffolk. Project Breathe is currently being implemented in 21 sites, including inpatient, ED, and outpatient practices across those 4 asthma coalitions. I have to tell you that it warms my heart when I think of how this project started as such a grassroots project, and it has really grown into 21 sites just over the last few years. Over the last 2 years, we've enrolled over 1,600 patients and their families as part of our Breathe intervention. These families receive comprehensive asthma self-management education from a multidisciplinary team, as well as referral to home-based asthma services. Certified home health agency partners are trained to implement home-based asthma services, and this team has completed over 800 asthma home visits. We will now dive more deeply into the Project Breathe implementation framework. Through practice transformation and quality improvement, Project Breathe aims to improve health outcomes for patients with asthma and their families by disseminating a sustainable, structured, customizable framework using a multidisciplinary team approach to asthma care delivery across settings. We build provider capacity to deliver NAEPP asthma guidelines-based care. We embed those guidelines into standard of care for all patients with asthma. We deliver comprehensive patient-centered care, including self-management education, follow-up support, and coordinated care across settings. We ensure care linkages through integration of referrals and bidirectional communication with community-based services. And we use ongoing data collection and monitoring to drive results and sustain improvement. Now I'd like to talk to you about how it looks and what you can do to prepare for success and launch of Project Breathe. So here's our model. We look to establish a team, lay a foundation, set the plan, deliver the resources, support the patient, develop those community linkages, and then we are ready, set, go. The first thing we have to do is create a team. Getting leadership commitment and engagement is the first step to a successful implementation. Engaging leaders at a decision-making level in healthcare systems will make for great programmatic success. It's also important to identify key partners, both internally and externally. And this list tends to evolve as you dig deeper into implementation. One of the real keys, though, to success for the project is creating that multidisciplinary core team. While the actual team members may vary if your project is in inpatient, ED, or primary care, it is key to have everyone who has care responsibilities for the patient to be part of the Breathe team. For instance, in the inpatient environment, we look to have hospitalists, specialists, nurses, respiratory therapists, pharmacists, child life, case managers, patient navigators, and certified asthma educators, all involved in the Project Breathe team. The next step is to understand how we treat our asthma patients. And again, unique to the setting, but we need to know what the asthma care looks like now. Excuse me. We conduct a needs assessment. We collect baseline data based on the data management plan provided by the Project Breathe structure, and we detail the patient journey. I feel one of the most important parts of getting the work done is to meet with the team and understand how asthma gets done. How do you do asthma in your setting? And that's why we call it the patient journey. When the patient comes to our door, how are they getting treated? Who do they see? How are things getting done? That puts us in a great listening position. Understanding where we are helps us to understand where we want to go. So now we have buy-in from leadership, we formed a team, and we know how our asthma work goes. We next need to set the plan of action. Developing a SMART aim with input from the entire team is necessary to guide the work and set outcomes. This can often take several meetings with the group. As you may know, SMART aims are specific, measurable, attainable, realistic, and time sensitive. Writing a SMART goal involves working through each of those components to build a measurable goal that encompasses what needs to be accomplished and when, how you'll know if you're successful. It also eliminates the guesswork. It sets a clear timeline and makes it easier to track progress and identify missed milestones. Sometimes when you meet with the teams, they're a little hesitant to actually put something on paper, but it's an evolving process and it really does set some nice parameters. We also have a menu of required and optional data measures to help guide the aim statement formation and eventually the data reporting. Oh, sorry. Our brief structure has now been assembled. We now move on to education. As the technical advisors to the sites, the ALA coalition teams provide staff training on NAEPP guidelines, ranging from assessing severity and control, adjusting therapy, asthma medication device training, assessing triggers, and spirometry. We have clinical asthma experts who provide these trainings to the core team. For the non-clinical staff, we offer the Lung Association's Asthma Basics, as well as a staff introduction to the tools we will be using. We train the team on the delivery of asthma self-management using our pictorial, low literacy, culturally appropriate tool, the Let's Take Control of Asthma flip chart. This flip chart is scripted so it can be used by any team member and has been piloted and validated through a small research project of one of our partners. This is our asthma flip chart. And you can see that there are no words that face the families, but there's a script in the back that can just be read. It's meant to be a tabletop stand. And it really does work to provide some nice asthma self-management education. Staff who are interested in becoming certified asthma educators are offered scholarships opportunities to take the course to prepare for the test, the American Lung Association's Asthma Educator Institute, and we offer scholarships for staff to sit for the test. Lastly, we provide training for quality improvement through the Institute for Healthcare Improvement, virtual coursework, and provide continual QI advisement as technical advisors. Here are some of the tools we use for the practical application of putting the guidelines into practice. This is our provider tool classifying asthma severity. We affectionately call it the circle tool. So a provider asks the questions that are on the top, circles the correct answer, determines the level of severity by the highest level of circle for each age group, and it also gives the preferred treatment. You can see the stepwise approach, which has not been updated for our for the new guidelines update, provides the information about what sort of medications we should be providing at that level of severity. We also have that same circle tool for assessing asthma control. Again, the physician asks the certain number of questions. They circle the answers that the family gives them. We actually laminate all these so we don't kill a lot of trees. We determine the level of control, and then we decide on our stepwise approach. We have also found it very useful to have an inhaled corticosteroid chart, which actually delineates all of the medications that are on formulary in each institution. Also, when we're assessing asthma control, when we're in the primary care setting, we use the asthma control test. So the families can answer those and be prepared for their visit. Along with one of our partners, the technical advisors develop rubrics for asthma self-management teaching to assess patient understanding. We have rubrics for device demonstration and teach back using a spacer with mask and nebulizer. There are required steps as you assess the patient's technique, and a score is noted. If the patient achieves a score of 80%, we document that the patient knows how to use the device satisfactorily. We use the same sort of rubric to determine patient understanding of their asthma action plan. Another tool that we train the educators to use is Why Use the Spacer tool, probably one of my favorite tools. It's a graphic that depicts the effectiveness of using a spacer or valve holding chamber in getting medication deep into the lungs. Our coalitions design QR code sheets that are available for providers to use for patient education. This sheet has codes for device demonstration, videos, what is asthma, and our newly launched asthma trigger house. Another tool that we provide across all of our settings is the respiratory treatment chart to help families identify pictorially medications they are currently using. You have to forgive my note using. I like being in front of an audience, but I feel like on the virtual environment, it's just a little different. It's just kind of a weird sort of setting, but I'm, like I said, so glad to be able to talk to you about our Project Breathe. So you're probably thinking that was a long way to go, and we haven't even mentioned actual asthma encounters with the patient. Well, here we are. What do we provide to the patient that will help us improve their asthma outcomes, whether they present to the ED, are admitted to the hospital, or see their primary care provider? We provide a Breathe toolkit, which varies slightly by site, but contains all of the tools that I mentioned previously necessary to conduct those assessments and provide asthma self-management education. The team ensures that every patient has an asthma action plan in the inpatient and primary care environment. Our ED asthma action plan process is still a work in progress. One of our stars for asthma self-management education, as I mentioned before, is our Let's Take Control of Asthma flip chart. Using the flip chart, device demonstration teaching and teach back, trigger identification, and referrals to home-based asthma services provides the framework for our patient interactions. When funding allows, the coalitions can provide take-home resources for the sites, including spacers, trigger trackers, and a brochure that reinforces the learning that has taken place. Once the patient leaves the actual site, we want to maintain a connection with them to further their learning and manage their care in the community. We do this through care coordination and follow-up. There's a lot of detail in our follow-up procedures, too many for us to go through in great deal here, and they're unique to each setting, but I'd like to give you some high-level steps that we use to keep that connection. Follow-up calls to patients post-discharge by clinical inpatient or ED providers happen usually within 72 hours of discharge and allow us to know if the family has seen their PCP, have scheduled their home care visits, and have picked up their medications. We look to answer any questions that may have arisen after their discharge. We also have looked in our past Project Breathe projects to conduct 12-month post-discharge calls with families to collect self-reported hospitalization and ED visits. We work with the team to coordinate linkages with school nurses and community-based organizations that help to address social determinant health needs that have been identified. We help the teams understand importance of the referrals to home-based asthma service needs and the value of the bidirectional communication between these community referrals and clinical care in the continuum of care for the patient. We have case management scripts for each care setting to use when offering these services to help families understand why they are important and that they are not going in to be a judgment of home or housekeeping or anything, any dynamic that is going on in that respect. And it's a tough sell, and it has been a little bit of an obstacle getting into the homes for COVID, but I must say that our home-based asthma service agencies have done amazing between virtual health visits, telehealth visits, and actually still going into the homes. Currently, our home-based asthma services are provided through certified home health agencies with visiting nurse services. Certified home health agency partners are trained to implement these home-based services, including environmental trigger assessment and remediation, medication reconciliation, asthma medication device training, asthma self-management skills training, and bidirectional referrals for social determinants of health needs. These nurses are also trained to use the rubrics for device demonstration evaluation and understanding of the asthma action plan. The coalition teams are often able to supply these agencies with supportive products for trigger reductions, such as pillow covers, mattress covers, vacuums, dehumidifiers, etc. The agencies also respond to any social determinant health issues identified and make referrals accordingly. Lastly, as I have been emphasizing, bidirectional communication, we have a home visit checklist that you can see on the, I guess it's my right side of the screen, that is used by the nurses to guide their visit and document patient progress. It then serves as a communication tool for the primary care provider to know what was done during the visit and any outstanding issues that should be brought to their attention. So we've done a lot of preparing for the project to launch. Now we're ready to go. Our kickoff event is usually something that we plan to introduce the actual healthcare system to Project Breathe. We often have a tabling event I should say most of this was pre-COVID, a tabling event in a lobby of a practice or of a hospital where we have lots of asthma resources, some goodies, some little giveaways. So people are introduced to the project. So they don't say, Project Breathe, what is that? We've used buttons and mugs and all kinds of things to get people kind of hepped up for Project Breathe. So that's kind of our kickoff event. Once the event is kicked off, the teams begin to have their regular technical assistance meeting. We use weekly meetings to start PDSA cycles to test changes in our process. We set an objective, make a prediction about what will happen, decide who, what, when, where, and how. We test on small scale. Remember, the one thing you don't want to do is throw everything up onto the wall and nothing sticks. So if you do small tests of change, you can really hone in on the things that are working, the things that are not working, and how you can tweak those and move them forward. As we run through our checklist, we continue to perform PDSA cycles until we come up with a formula for getting to our SMART aim. We do a lot of monitoring and evaluation. We use the Institute for Healthcare Improvements extranet for reporting and tracking monthly data and the measures that have been set forth by the New York State Asthma Control Program. The teams are responsible for monthly reporting and use of data run charts to inform the PDSAs. And I think for me, that's one of the most important parts of the project is giving monthly feedback to the teams. So perhaps one of their measures is that 75% of everyone who leaves the primary care practice will have an asthma action plan. Well, by entering the data into the extranet, we're able to produce run charts and present them at the team meeting so people can see how's it going. Oh, there was a dip this month. What happened? Well, Dr. So-and-so was out on maternity leave, so some of that fell by the wayside. Oh, okay, so now what do we need to do to bring all those measures to where we want to go? So it's a really important part of the project from my perspective, and I do love sharing the data, especially when people are reaching their measures, and it gives people a real sense of accomplishment that they're moving the continuum of the asthma outcomes. So the Project Breathe implementation framework is the structure upon which we build our individual projects. I've outlined the key components which we know lead to improved health outcomes for patients with asthma in the different healthcare settings. To recap, through practice, transformation, and quality improvement, Project Breathe aims to improve health outcomes for patients with asthma and their families by disseminating a sustainable, structured, customizable framework. Remember, we customize every single project to the setting that we use it. We use a multidisciplinary team, such an important part of Project Breathe. We build provider capacity to deliver NAEPP asthma guidelines-based care by our comprehensive education system that we have set up. We embed those guidelines into the standard of care for all patients with asthma using workflows and swim lanes and all of those tools to help people understand how those guidelines get embedded. We deliver comprehensive patient-centered care, including asthma self-management education, follow-up support, and coordinated care across settings. We ensure that those care linkages through integration of referrals and bidirectional communication with community-based services to address social determinants of health are in place and operational. And we use ongoing data collection and monitoring to drive the results and sustain improvements in each setting. So in conclusion, the development of Project Breathe New York has been built on national, statewide, and local programming. We looked to the CDC for national funding to address asthma. Their C-Care and Exhale technical packages have provided a backbone for the works that we do. The New York State Department of Health has provided funding to address New York's highest asthma burden regions, as you saw on the map of the coalition work. They have provided us with an infrastructure and coordination to drive the Exhale package implementation using a systems approach. The American Lung Association has regional partnership engagements in the implementation of Project Breathe throughout New York State. We offer the training and the technical assistance, and we also support advocacy and policy throughout the state. We could not do any of this work, though, without our Project Breathe partners. Our managed care organizations drive physician and health system engagement. They prioritize asthma quality measures, support evaluation. Our health systems ensure leadership engagement, convene project sites, embed the workflows. They empower the multidisciplinary care team, and they engage the patients and their families. Our multi-sector partners support the coordination of care across settings, clinical, home, school, and community. We've established referral systems with bidirectional communication and addressing social determinant health needs, all which lead us to providing guidelines-based care using the NAEPP EPR3 2007 and 2020 focused guidelines updates and the Global Asthma Initiative guidelines in order to provide quality care accessible by all patients with asthma. So I think we have a little time for some questions.
Yeah, Claudia, thank you so much for that presentation. I think it was really valuable to see a real program in action and learn from your successes.
Thank
It
you.
looks like we do have one question in the chat so far, and we have about 6 minutes for more questions. So everybody who's in attendance, you can either add questions to the chat or we'll open it up. I'll start with this question that's in the chat. Related to the different infographics that you had about the different medications. This person is saying that a lot of times patients won't know what like their medication name is or what they've been prescribed necessarily. are there resources available from the American Lung Association related to some of those images that you talked about?
Yes, actually, we have Know Your Difference. Hope I say it the right way. It's Know the Difference, and it's an infographic that shows the difference between quick relievers and controller medications. And this was a collaboration of the Asthma Coalition of Long Island and their local New York State Children's Environmental Health Center, and some local legislators in Suffolk County. So we do have that. And we have other medication infographics that are available from ALA, and we can provide you with actually it's lung.org. So it's kind of an easy access, but we do have quite a few of those tools that we can provide to you, as well as through our asthma coalitions.
Okay, great. That looks like the last question from the chat, and I'll open the floor to the participants. We have about 5 minutes. Does anybody have any questions for Claudia while we have her in the space?
Actually, I have something I thought somebody might ask about the timing of Project Breathe. And I realized when I developed this, like, what is the timeline, right? So we talk about getting all these things in place. And I would say for a good Project Breathe implementation to get established in an institution pre-COVID, although we've had quite a few implemented virtually through COVID, I would say 12 to 18 months is the usual continuum of the program. So from the first day that you have that meeting with the leadership in an institution until you're kind of kicking off and boots on the ground and really starting to collect a good bit of data, it probably is about 12 to 18 months of timing to get a good Project Breathe project off the ground.
Great. Okay. Thank you for sharing. That was a great question to go ahead and proactively
I thought about
answer.
it as I was writing my notes.
We'll give everyone a couple of seconds if you guys want to unmute and ask any questions. And to unmute, you would just use your bottom left button. If you're having any issues, feel free to use the chat as well. Claudia, you're getting some bravos.
Thank you. And to the person that asked the question about the pictorial the pictures of asthma inhalers, we actually use that in a lot of ways, right? So it's my favorite tool. It's always on a bulletin board wherever I am. And my home office, it's here, although I think I gave it to somebody because I tend to have those pads everywhere. But one interesting thing that came up with those, the tool that I showed, which is the through the Asthma Network, was one of the nurses at one of our hospitals said, you know what, I love that tool, certified asthma educator. And she said, but what I like to do is, could you give me some of those pads so that when I discharge a family, I will circle what they're supposed to get, and also then explain to them, you know, if you don't get the ProAir RespiClick, you might get something that looks like this. Understand that in these medications, they work the same. So don't panic. And so it's been kind of a little pilot that we started working on before COVID. So more to come on that, but really is important. It's also important in the ED. We show people pictures of inhalers, and, you know, they use the blue one or they use the green one. So if you have something pictorial, which we're very big on pictorial resources. So that is something that we use. When I first started working in Queens, which is a borough of New York City, we are the most diverse county in the country. We have 176 different languages spoken and dialects. So I kind of had to change my asthma thinking and said, oh, you know what? We need pictures. I can't come up with words. I can't come up with 176 dialects to translate all my material. So how do I get a message across? And that's through pictures. I'm a very visual learner myself. So if I'm looking at something, I'm reading it. I don't hear words you say till I'm done looking at it or reading it. So it was really very eye-opening for me and has become sort of a passion in terms of literacy for me. I will, full disclosure, say many of our materials are translated into Spanish because we have a very large Spanish-speaking population in New York, and actually not just in the city, but throughout New York State. And because I worked in Queens, which had a very high Asian population, we did translate some of our materials into Mandarin. And we will translate some of the brochures that families go home with into other languages, but things like, you know, our flip chart, it's really just English and Spanish, and we use translation lines to, you know, get the job done because it's a much more cost-effective way to get the materials out there.
Wonderful, wonderful. And I think that's a great lesson to learn in all of our public health efforts as well. So Claudia, thank you so much for your time. We really
Thank
appreciate
you.
it. We're going to have a 5-minute break, everybody.